Thanks. All right, thanks for having me. So just wanted to go over, I think, an important topic that oftentimes is overlooked in IBD patients, which is their healthcare maintenance. So the objective of the talk is to briefly review the screening recommendations for immunosuppressed and non-immunosuppressed patients with IBD, to highlight the data behind some of those recommendations, and to expand the current paradigm of IBD-related preventative care and healthcare maintenance, which I think is an important one. So just to dive in, there are going to be, the first thing to mention is that patients with IBD may receive various degrees of immunosuppression over their lifetime, each resulting in different risks for developing secondary pathologies. And so screening has become very important, not just in the colon and the intestine, but extraluminally as well. And the importance is to decrease the risk of developing secondary cancers and other serious adverse health outcomes. However, it's unclear who's best to lead these pursuits. Oftentimes, it's a discussion between PCPs and GI doctors, and so this leads to a potential significant gap in IBD care. And so this was actually a study from 2008 that polled primary care physicians, and essentially what we see is they asked a few different types of prompts to them. These are different IBD patients, and what you can see is they basically were asking how comfortable are you providing basic primary care to these patients. And for the vast majority of these patients, it was less than 70%. And the thing that really stuck out to me was it's these patients who are on medications for IBD, specifically immunosuppressants. There was a 50%, 60% comfort with treating them from a primary care perspective. And so, this does lead to significant lapses in their screening efforts. And this goes beyond just immunizations, right, for these patients who are immunosuppressed. This includes things like lipids, which we see in this study from the University of Kentucky when they compared IBD versus controls, that there was a 15% decrease in the amount of lipid profiles that were being checked. They also saw that there was a decrease in dietary counseling as well. And they actually compared to the University of Chicago as well, and there was a significant drop-off there in addition. And so really only 75% of patients with IBD in this cohort had received adequate health maintenance. And so the four topics I want to talk about, because this could be very vast, but to keep it a little bit more succinct, are immunizations, cancer screening, bone health, and mental health. And so the first topic is immunizations. And so the thing to note is, all adult patients with IBD, regardless of their immunosuppression, should receive age-appropriate non-live vaccines per CDC guidelines. Those include childhood vaccines, influenza, Tdap, COVID, Hep B. Those who are immunosuppressed should also undergo accelerated immunization, which we'll go over in a moment, but also avoid the live vaccines I mentioned, specifically for this patient population, and that includes the MMR and live varicella vaccine. Despite IBD patients representing a higher-risk patient population, the rates of immunization are quite low. This is an older study from 2011. I think post-pandemic, things may have gone up. But this was a study where they looked at 13 common vaccinations in adult IBD cohort, and you find that really anything other than tetanus has less than a 50% vaccination rate. And so again, maybe this is not as reflective as the patients that we see at Mount Sinai, maybe it is, but it goes to show that there are pretty low vaccination rates overall. And so the question is this just because of the primary care providers? Is this because of GIs? Is it a bit of both? So this was a study from 2011 that polled actually GI providers who took care of IBD patients. And what you see is that about 50% of the time, the providers are asking less than half of their visits about their vaccinations and if they're up to date. And so I think the other thing to note is that they then asked, is it not just you not having time, for example, to ask about this, but also just wanting to understand a little bit more as to whether or not they were actually up to date in their knowledge about immunosuppression and vaccinations. And what was striking to me was that the study looked at, and they found that in immunosuppressed patients, a quarter of them were recommended to have live vaccines by their gastroenterologists. So again, this study went to show that there is a significant, gap in both the time that we have to be able to ask these questions, but also knowledge in certain cases, in part because the vaccinations for the CDC have changed over the past 5 to 10 years. And so, this is a CDC guideline that looked at, patients who have various degrees of special circumstances, from pregnancy to certain levels of immunocompromised status. And what you see is that for the vast majority of them, they recommend, again, these age-appropriate vaccinations, which include the flu, Tdap. It also includes HPV for those who are under 45, and as well as a few others. But for specifically our immunocompromised patients, which basically fall into this bucket for the CDC, what they recommend is, in addition to age-associated vaccinations, as mentioned, avoiding live vaccines like the MMR and varicella vaccine, and also giving at an accelerated rate the zoster vaccines, so Shingrix and pneumococcal. And so to specifically talk about shingles and pneumococcal, which I think are important, especially with the advent of new medications like JAK inhibitors, for herpes zoster, also known as shingles, all adult patients with IBD should receive 2 doses of Shingrix, administered 1 to 2 months apart if they're on immunosuppression. If not, then 2 to 6 months apart, which is the standard of care. This is the CCFA guidelines, which actually differ from ACG and ECHO. They recommend all patients, regardless of their immunosuppression, should be vaccinated for herpes zoster. I think the idea being that we don't know how these patients are going to progress in their care, and so oftentimes being able to have herpes zoster vaccinations up front before we have to start rescue therapy, for example, is important for these patients. But the ACG and ECHO really say this should be for immunocompromised patients below the age of 50, and then older adults who are 50 and older. However, I think one other thing to think about here is that we need to prioritize patients who have higher risk immunosuppression, like those with JAK inhibitors. Additionally, for pneumococcal vaccinations, what all of the guidelines, the CCFA, ACG, and ECHO recommend is vaccinating adults greater than the age of 19 who are on systemic immunosuppression. And so if patients are vaccine naive, they actually have just developed this past year the PCV21, which I'm not sure if we have in IBD center. I think we have the PCV20 at least, most recently I checked. Either are adequate for these patient populations. And then if patients receive an older PCV vaccine, they would then get the polysaccharide vaccine thereafter in 8 weeks. For those who had been previously vaccinated, the big takeaway here, and again, this is all on the CDC website, but is that if they've gotten one of these vaccinations that are older, they should get the newer vaccine, the PCV20 or 21. If they've gotten both, they should get it 5 years after. So just really the timeline, 1 year versus 5 years.
And for the shingles, it's just one for life.
So yeah, they don't have recommendations about if you vaccinate someone at 20, for example, if they need to have secondary Shingrix at 50, like other patient population. For now, all the CDC recommends is 2 doses.
But
just one time.
Just one time for your whole life.
Yeah.
Even for me, for instance.
Yeah. No,
That's why he's asking.
Yeah. Well, in patients above the age of 50.
Exactly.
No, for our common, like for normal patients above the age of 50 who are recommended, it's just the 2 doses, the 1 time.
Because I just encountered this issue with someone who had gotten Shingrix a while back, and I had them see infectious disease because they got, they were on immunosuppression. They got another round of shingles years after getting it, and they told me that on average it's about 7 to 10 years effective.
Okay.
So, again, I'm not telling people to get it done every 10 years, but I don't know.
They gotten the live shingles vaccine?
No, the Shingrix. Yeah, they were like one of the first people to get it, and they had breakthrough while on, I think it was one of the JAK inhibitors. So, I'm not sure. I think that's going to be a guideline that's going to need some tweaking.
So it's a good point. Is that for patients who've had shingles, for example, the CDC doesn't go over those who had been vaccinated for Shingrix prior. They strongly recommend giving Shingrix thereafter because it does decrease adverse effects and recurrence. So it's a good point. If you had Shingrix before, developed shingles, there may be some utility in revaccinating them, but it's a case by case conversation.
Yeah.
And so the quick data behind this has been by Millie Long. In 2013, 2015, she had some very nice work that looked at zoster pneumonia. I'm just going to look at this briefly. So for zoster, what they did in this study in APT was essentially they looked at zoster throughout life. This is for, again, herpes zoster, not primary varicella infections. And so what they compared was Crohn's disease in UC versus healthy controls. And what you see for Crohn's disease, for example, there's more than a 2-fold increased risk, regardless of age. Additionally, for UC, it's a little bit more of a modest effect. But this was one of the reasons as to why I think the CDC has adopted, at least for IBD patients, potentially vaccinating earlier. Additionally, what they would want to ask, which is the obvious question, is what about these patients' level of immunosuppression? And the short of it is that all levels of immunosuppression, whether it's biologics, immunomodulators, or corticosteroids, all confer increased risks of developing herpes zoster. Similarly for pneumonia, we see that again by Millie Long in 2015 in the Red Journal, that patients with Crohn's disease had over 2-fold increased risk of developing pneumonia, and that this was a little bit more modest in the UC group as well, and that this risk was really driven by specifically corticosteroids. Patients who were on thiopurines and biologics had a modest increased risk, but really it was the corticosteroid group that really drove this. And so this goes to the question of levels of immunosuppression. So for the most recent ECHO guidelines, the question really for our patients is, does this apply to patients who are on Entyvio? Does this apply to patients who maybe are on IL-12 and 23 inhibitors? The answer is we don't know. And so oftentimes what ECHO has recommended, and some soft recommendations from the ACG, is to just vaccinate patients on a case-by-case basis who may have some more modest levels of immunosuppression. And so the last few minutes, I just wanted to briefly talk about cancer screening, which we all know, and we'll talk about a little bit later, colorectal cancer and dysplasia surveillance for patients who have more than a third of the colon involved for more than 8 years, or PSC patients on diagnosis. We'll talk a little bit more about the colonoscopy and whether to do targeted and or non-targeted biopsies. And the short of it is this should be done every 1 to 3 years for the CCFA and 1 to 5 years for AGA and ECHO. But for PSC, it should be annual. Additionally, this is actually an important one too, is that for cervical cancer, because these patients who are immunosuppressed have an increased risk of HPV reactivation, pap smear should be done actually annually if it's cytology alone, which is increased compared to the baseline. Or it should be Q3 instead of Q5 years for cytology and HPV. And then for skin cancer, again, anyone who's on systemic immunosuppression should have a full body exam, skin exam done by their dermatologist. And just to run through this briefly, osteoporosis screening, we recommend central DEXA scans if you meet any of the following criteria. So a lot of our patients have more than 3 months cumulative exposure to steroids. They may have a low BMI. So the recommendation is actually to screen them at this point in time and then to follow up every 3 to 5 years if it's normal. And the reason for which is this was a study from Charles Bernstein in 2000, older study, but essentially what they showed was that IBD patients as a whole had increased risks of fractures in the hip, spine, wrist, rib, all of them together. And so really being progressive or sort of proactive about their screening in this way is important. And the last thing I want to talk about, which was mental health, as we all know, about 25 to 30% of our patients with IBD have concomitant anxiety and or depression. I think it's important to know this pathway that is bidirectional, both with the gut and the brain. Anxiety and depression are associated with clinical recurrence and decreased treatment response. This was a study from 2004 that essentially showed that patients who had a concomitant anxiety or depression, this was specifically depression, had an increased risk of, or had decreased remission rates compared to those who did not have concomitant anxiety or depression. And so IBD should be screened annually for G87 or PH29. And so if it's positive, the first line would be counseling or therapy. And we have a great mechanism here at the Grit Center, and others would, can refer out as well. And so this is just an example of what the PH29 and G87 is. So my last slide is just sort of a summary of the recommendations. This is also a QR code for the CCFA health maintenance checklist, which I think is very, very helpful and very encompassing and adds a few extra things that I didn't have time to cover today. And then questions.
Because we have seen you on, we'd like to hear from her and Sergey about the surveillance of perianal for the risk of cancer, because this is more recent. So maybe Sinu, you can comment on that? Sinu? Yes.
Sure. Hi, can you hear me?
Yes, yes.
So as you all know, it's a very rare occurrence, but there does seem to be a higher occurrence of fistula-related cancers. We recently conducted a systematic review and then conducted a consensus statement on this. And it's there's very little data because there are so few patients, right? So there's not a lot of sort of evidence base that we can use. That being said, there were a couple of things that came up. One is, really to pay attention to HPV and screening for risk factors for HPV, and also so that we can sort of navigate patients towards anal PAPs as needed. And then the other point, and because there is, still a population of patients who did not have HPV vaccinations, because that came after quite a few people became adults already. The other point is really if you have a patient with long-standing perianal fistulizing Crohn's disease, that if you either have persistent symptoms or new symptoms after a long-standing period of remission, that one of the things to consider is a cancer. And so for that, you know, you really have to work, we have to work together, the gastroenterologists and the surgeons. If someone's going for EUA, often enough the surgeons will do this already, but you might see or might inquire about having a biopsy of the fistula tract.